It's great to be here with all of you. My name is Daniel Hougendobler. I'm a law fellow, as Jen mentioned, at the O'Neill Institute for National and Global Health Law. We focus on law as a tool for solving pressing global health and domestic health issues. So I will just hop into the next slide here. So just to give you a brief outline of my talk. They're all one. I'm not sure how that happened. But I'm going to share my thoughts on laws, a tool to promote global health, walk us through a case study, which is Ebola, as we talked about briefly at this conference already, and then offer a few concluding thoughts. I hope you guys feel free to interject at any time if there's anything that's unclear or if you have any burning questions, but we'll have time at the end as well for discussion. So there's a long history of using health as a tool to protect domestic health, as many of you know. And public health law is a pretty defined field. Global health law, on the other hand, is really still nascent. And besides there were a few weak treaties, mostly dealing with infectious disease in the 1800s, but really the field has only come into its own in the last maybe 2 decades or so. So we're kind of right now at the cutting edge. And still thinking deeply about a lot of these issues. And as the world becomes increasingly globalized, international law is going to become more important, and issues of global health law are going to have an increasing importance. So I'll just start with the definition of global health law. This is from Lawrence Gostin's Global Health Law book. This is the first textbook on the field. It came out last year, so you can tell it's not a very well-defined field yet. So first, it's the study of international law, like I mentioned. So that includes hard law, which is what most of you might think of. These are binding agreements like treaties, conventions. There's also soft instruments, which some people may not think of as law. These are kind of quasi-legal agreements that have normative power, but not necessarily any sort of legal authority. But they're still negotiated between international actors like states. And global health law is interested in how international law shapes norms, processes, and institutions, and how those promote global health. And then normatively, we try to advance the law to mobilize resources, set priorities, coordinate activities, monitor progress, create incentives, and ensure accountability. So just a brief overview. And then I'm just going to give you a few examples, since that's a very esoteric definition. So for hard law, which is binding law that has legal force, there's a framework convention on tobacco control. That's kind of the quintessential global health law instrument. And that was negotiated at the WHO, World Health Organization. Then there's some agreements that don't really consider health but have impacts on health, and that also is part of global health law. So for example, there's the TRIPS agreement, the agreement on trade-related aspects of intellectual property rights, which you'll hear a lot more about later today, probably from Peter. And then there's human rights treaties, which is one of the themes of this conference. So for example, the International Covenant on Economic, Social, and Cultural Rights, which was negotiated at the United Nations. And then soft norms are, for example, the Pandemic Influenza Preparedness Framework, and that's an agreement on virus sharing. So when you collect samples in a country, who gets to see those samples and who gets the benefits of those samples, so who gets to share the vaccines and any other biological materials that might come out of those samples. Sustainable Development Goals, that's something that's been in the news a lot lately. They're the successor to the Millennium Development Goals. They're not binding, they're just a statement of goals and aims and kind of development priorities. And then there's codes of practice are a very common type of soft law. So these are things like the WHO Global Code of Practice on the International Recruitment of Health Personnel, which is basically to prevent brain drain, so that developed countries don't just recruit all of the health personnel from developing countries, which has been a problem in the past. So I'm going to focus today on the International Health Regulations, which is a binding law that was negotiated at the WHO, and it's meant to detect and prevent the spread of disease across borders, and at the same time try to keep states from overreacting and needlessly impacting international trade or human rights. The first edition of the treaty was in 1969, and it only applied to 4 diseases: cholera, plague, yellow fever, and smallpox. I think, so some of you might remember, in 2003, there was an outbreak of severe airborne disease that had pretty high mortality rate, centered in Hong Kong. This spread internationally pretty quickly. There was a big outbreak in Toronto, and people were very worried about it. And I think the consensus was that the international community didn't do enough, and the Chinese authorities didn't do enough to disclose the disease early enough, and it did a very poor job of containing the disease. And so that was in 2003, that spurred the development of the international health regulations, which were passed in 2005. And so the 2005 agreement broadens and strengthens those, the 1969 regulations. It applies to a much larger group of diseases, pretty much any novel disease, and so there's some mandatory reporting diseases, and so it's a much broader agreement, and it has more teeth. So let me this. The IHR, like I said, is negotiated with WHO. International organizations, and I'm sorry I'm getting so much into the weeds here, but I think this is important to understand for understanding how the IHR has its power. The international organizations are given law-making authority through their constitutions, and the World Health Organization has particularly broad powers among international organizations. So generally, states have to expressly accede to a convention or a treaty. With the WHO, they actually, for certain types of treaties, states have to opt out. And IHR is an example of that. So states actually have to affirmatively say, I do not want to be part of this. And so as a result, every WHO member is actually a part of the IHR, as well as 2 non-WHO members. So pretty much every country in the world almost is a member of the IHR. So that's a very, one of the most subscribed to treaties in the international system. And as I mentioned before, the purpose is to prevent, protect against, control, and provide public health responses to international spread of disease, while also avoiding unnecessary interference with international traffic and trade and impacts on human rights as well. So basically, it's an early warning system, and it's supposed to trigger containment at an early stage. And I promise this is one of the last slides on the legal provisions and the depth. So the IHR imposes a lot of requirements on states. First, states have to establish a national focal point. This is basically a phone number that the WHO can call day or night, and someone will pick up. So it's sort of like that red phone that they had in the Soviet times, where you pick it up and you get the Soviet Union. In this case, the WHO picks up and they get the national government, somebody who has authority to act for public health. The most important provision is that states have to report on potential public health emergencies of international concern. And if you look at this chart on the right, that's the decision instrument that's actually an annex to the IHR. And basically, there's some diseases that always have to be reported. So for example, polio, smallpox, which is supposed to be eradicated, so you definitely want to report on that. Novel influenza and SARS are always reportable. For other diseases, there's a more nuanced decision tree that depends on the severity of the disease, whether it's novel or has a track record of international spread, and whether the outbreak is unusual or unexpected. Once the outbreak is reported to WHO, then the Director General can decide whether to convene an emergency committee to consider the outbreak. This is all up to the Director General. She can decide whether to convene or not convene, and she also decides, based on the recommendations of the emergency committee, whether to declare a public health emergency of international concern or not. And if she does declare a public health emergency, then it triggers certain responses, and also she has the opportunity to make recommendations to states about how best to respond to the outbreak. And the states have 2 additional obligations under the IHR. First, they have to develop and maintain the minimum capacities to detect and respond to infectious disease. And they must also, like I've mentioned a couple of times, avoid excessive restraints on trade and protect human rights. This was a problem in the SARS outbreak. A lot of people think that the international community overreacted. There were massive culls of animals. There were restraints on trade. Travelers' human rights were, in some cases, impacted. So a lot of this is a response to that that kind of knee-jerk reaction that we have. And we'll talk about that a little bit more in the context of Ebola. So I'm sure all of you are very aware of the Ebola outbreak that happened in West Africa over the last probably year and a half at this point. The outbreak centered on 3 countries: Liberia, Sierra Leone, and Guinea. And Ebola is not really anything new. There have been outbreaks pretty consistently over the last decades that we know about, and I'm sure there are a lot that we don't know about as well. But the West African outbreak was different in several ways. First of all, of course, it was much more severe, a lot more cases and a lot more deaths, much more than all the other outbreaks combined. It hit a region that had exceptionally poor health systems. They were post-conflict states that they had very few physicians and no real detection or response capabilities. And West Africa actually hadn't really seen outbreaks of Ebola, at least that we know about. They're usually centered in Central and Eastern Africa. And so doctors and healthcare providers didn't really know what to look for. And Ebola, especially in its early stages, is very easily confused with other very common endemic diseases. Then it also hit urban areas for the first time. Usually their outbreaks are rural because it's a zoonotic infection, so that means it goes from animals to humans. And so they crop up in rural areas from bushmeat consumption, things like that, and then quickly die out. In this case, it hit several urban areas, including Lagos in Nigeria, which is like one of the biggest cities in the world, capital cities in all 3 countries. So that was part of it. And then also there were cultural practices that I think that exacerbated the spread of the disease. For example, the death rituals, where you bathe the body and you're in very close contact with the blood and other fluids after a person dies. So up till now, it's been a really devastating disease. I think there have been about 25,000 cases, probably a little more now, and 10,000 deaths. It's also a very high mortality disease, as you know. So as you can see from the curve, we're getting there in terms of the response. It's really tapered off, especially I think in Liberia they're about ready to declare it Ebola free. Sierra Leone is doing pretty well. Guinea still has some outbreak, but you really have to get to 0 before you can say it's over, because one case can spark a whole new outbreak and epidemic. So we're not there yet. I think in the last week there were about 40 new cases, which is actually a little bit more than the week before, so still work to do. I'm just going to give you a brief timeline of the disease and the international response. So in December 2013, they think that the first index case, they think it was a 2-year-old boy who was infected in Guinea. In March, the outbreak was first identified, so it took from December until March before they realized there was a problem. And delay, like I said, it's easy to misdiagnose Ebola, and that happened very often. There were hardly any health workers, so a lot of people just died in their homes without ever seeing a health professional. And the health systems were just very weak in general. By late June, it had really spun out of control. It was in 60 locations across 3 countries. Médecins Sans Frontières called it out of control, and they called for a massive deployment of resources, which didn't happen. By July, this is when actually international attention was put on Ebola, when 2 infected USAID workers, of course, came back to the US, and so it kind of came home to the Western world that this epidemic was happening. It's sad that was what it took. And Ebola spread to Lagos, like I said, which was sparked a lot of fears that it would spin out of control. And this is an interesting example because Nigeria only had a few cases. Their health system is much stronger than the other 3 countries, and they were able to contain it quickly. And so it didn't really ever become a huge epidemic in Nigeria like it did in the 3 countries. Just goes to show how important health systems are, as we heard from some of our panelists before. And then it took until August for WHO to finally declare a public health emergency of international concern. Margaret Chan, the Director General, to offer temporary recommendations. In September, the response really got rolling. The UN Security Council held a special session. They've only done it once before for HIV. The UN Mission for Emergency Ebola Response was created. That was the overseeing authority. And the US deployed 3,000 troops, mostly to Liberia. And that was when it really churned. That's when the lines start to kind of smooth out a little bit. At one point, CDC was saying there could be hundreds of thousands of deaths if it wasn't contained, and so far we only have 10,000. So the international response really did make a huge difference. Oops, I'm sorry. And then, so for September till April till today, we've dramatically lowered the cases, but like I said, there's still a worrying number of new cases, and it's certainly not contained at this point yet. So, unfortunately, the IHR, as you probably can see, has basically failed in the context of Ebola. Detection failed. The international response was very slow in coming, and really, when it did come, it wasn't WHO that led the effort. It was the UN and the United States. And I'll just go into a little bit about why it failed, and then offer some suggestions for strengthening in the future. So the IHR failed for several reasons. Countries weren't able to cope with Ebola, first of all, because they lacked the capacity, like I've mentioned. It took from December until March before it was even identified and reported. Whereas under the IHR, states are supposed to have capacity to detect outbreaks. These three countries obviously did not. And the weak health systems made it much more difficult for them to contain the disease, and they just lacked the surveillance infrastructure. And so the IHR requires countries to build capacity, but doesn't really speak to countries that just don't have the money, the resources, the know-how. It says it has a vague provision to the extent possible, which really doesn't mean anything. That's a really good example of a non-binding clause. And so I think that's one of the big flaws of the IHR, is that it doesn't speak to that issue of increasing capacity for countries that can't afford to do so themselves. And the WHO took way longer than it should have to declare public health emergency of international concern. Recently, I read an article about some emails that have been covered. Were really interesting about why it took so long, and some of them were kind of understandable reasons. Like, they were worried about the economic impact on countries. I think that was very misguided, but it was, looking out for the interests of the country. They're also worried about the annual pilgrimage to Mecca, whether it would deter people from going. I'm not really quite sure why that was such an issue, because it was never in the Middle East. But and just a variety of political concerns as well. And another reason is in 2009 there was the H1N1 pandemic. I think a lot of you remember that as well. And the WHO was very strident. They declared a public health emergency of international concern. They declared it, I think it was like a stage 5 pandemic, which is like the highest level. And it really ended up kind of petering out, not really being a big issue. And I think the Director General was still kind of reeling from that, the political ramifications of that. And so I think she's been more cautious about declaring a public health emergency of international concern because of that. But for whatever reason, it took far too long. The international response took far too long. So that's something that I think that the international community needs to examine. And then there's systemic problems. The IHR's host organization, the World Health Organization, is very underfinanced. I think the US CDC has about 3 times the budget of the World Health Organization, with a much, much larger mandate. And recently, especially with the financial crisis, the level of funding for the WHO has decreased. There have been layoffs of key staff. A lot of infectious disease, pandemic preparedness staff actually were laid off, anthropologists and people who, epidemiologists and people like that. And then a lot of the WHO's contributions are actually earmarked for specific purposes. So when something like Ebola comes up, they don't have the discretion to move money around and respond to what they see as the most pressing threat. So, and states are assessed contributions but are notorious for not paying them, so there's a lot of problems with the finances. And then the other problem is that WHO is actually, kind of surprisingly, one of the worst at integrating non-state actors into its decision-making process. It doesn't really have a formal role many times for them. And so, for example, like I said before, MSF had been calling for resources for months before the WHO finally responded. I'm not sure that if they had had a more formal role, that they would have listened, but at least they would have had that formal ability to raise those concerns at the organization. So I'm going to look really quickly at what we need to prepare for the next pandemic. How do we strengthen the IHR? I think the key lesson is that international law does not operate in a vacuum. No matter how well worded a law is, how binding it is, it's part of an ecosystem, and you need institutions, politics, finances, and everything to complement those laws. And the ecosystem just failed for the IHR. I think it's at its core a strong instrument with a few minor flaws, but generally good. I think the problem wasn't the IHR so much as all the things around the IHR. So first, the IHR needs a stronger host organization. We need WHO to be reformed and strengthened. First, this means adequate funding that's commensurate with its global mission. States need to pay their assessed contributions, and funders should be more willing to give the WHO unrestricted funding rather than tying it to specific purposes. I think this actually speaks to a lack of trust of WHO. They're saying you can only use your money for maternal health because we don't trust you to make these decisions, and I think that really ties WHO's hands. And global health is a really fast-moving field. You can't really predict what the health concerns of next year are going to be, for sure. Internally, the organization needs to strengthen its normative role. It's only negotiated the IHR basically in the Framework Convention for Tobacco Control. Despite its really broad lawmaking powers, I think a stronger normative role for the organization would help to prepare for pandemics, as well as other things like the rise of non-communicable diseases. And then also, like I mentioned before, it needs to become more inclusive and transparent, with a larger role for civil society and non-state actors. So this is a little bit, it's a little bit off topic, but originally I was going to talk about the Ebola response and this success story, but I realized there was too much to talk about for Ebola, so I left this out largely. But I don't want to leave on the note of a failure. This is something that some colleagues and I worked on a while back. This instrument that was passed in the aftermath of, or at the peak of the AIDS epidemic in 2001. The UN General Assembly came together for a special session on the disease, and they agreed on this non-binding soft law instrument to report on the epidemic, disaggregated data, and so unlike the IHR, this was just unlike the IHR, this is a non-binding agreement, but actually much more successful in a lot of ways than the IHR. Over 95% of countries that signed on to the agreement have actually participated and given data. And of course, there are some data quality issues, but it's actually probably one of the most successful stories in global health law. And we argue that one of the reasons is that it had really strong institutional support. UNAIDS gave it adequate funding, and states perceived it as very legitimate and fair. So anyway, I'm happy to talk about that more in Q&A, but I didn't want to leave you guys with the depressing Ebola example. So yeah, thank you. This is my contact information. I'd love to talk to you more after, and I'm happy to take questions. I think we have some time for questions.